You're on.
All right. Thank you, Patty, for inviting me. This is my first talk on a very important topic that we've talked about for many years, but we've really never got a real handle on this until recently. There's been a lot of literature. And again, I'm going to talk about delirium in the ICU. Of course, I'm not going to be able to cover everything because it's a huge topic. So the reference here, ICUdelirium.org, is an excellent website, which is from Vanderbilt University, where most of the work and almost all of the research on delirium over the last 10 years has been done by the group at Vanderbilt. Dr. Pandra Pandey, Wes Ely, Brenda Pond, and group have done an outstanding amount of work on delirium in the ICU. It really changed our whole perspective. Okay, so delirium is basically an organ function, just like we think about ARDS, renal failure, okay, heart failure in a patient in the ICU. We need to start thinking about the brain dysfunction in the ICU as part of the organ failure, okay? And that's what really delirium is. And there are many things that make delirium a lot worse, and we'll talk about a lot of these things. And I think that there's so many components to delirium. Most of us think maybe withdrawal from alcohol or chronic benzos, sleep deprivation, substance abuse, the noise level, the sedatives that we use in the ICU can contribute, advanced age. However, it turns out that younger people are just as much prone to having delirium. Severity of illness, medical comorbidity, pre-existing dementia or cerebrovascular disease if they've had multiple strokes. There was actually, delirium has had so much exposure recently that this was in the New York Times. If you want to watch an excellent video, just Google ICU nightmares from the New York Times. Okay, if you ever get a chance, watch that video. And there's many videos from Vanderbilt too. So I think mostly what we want to try to do is recognize delirium, right? 80% of the patients that have delirium in the ICU, oddly enough, we don't even recognize it because there's a lot of misconceptions about delirium. We always expect patients to be pulling their Foley out and their central lines and jumping out of bed. And if you just diagnose those patients with hyperactive delirium, you're going to actually miss about 60 or 80% of the patients that are delirious because we just don't know how to do it. That's why now there are tools to recognize that. So it's not always agitation. Certain things will make delirium worse. A Foley catheter, restraining patients. Actually, any foreign object, any foreign body that you use, central lines, Foleys, will actually make delirium worse. Why? Because they keep us awake at night. Okay, the pain from all of these interventions actually makes things worse. And if we don't treat their pain, we actually make their delirium worse. So a big focus now in terms of managing delirium is to jump all over the pain right off the bat. Okay, and so the focus of the Society of Critical Care Medicine in the ICU is called the Pain, Agitation, Delirium Guidelines, PAD guidelines. So you often see me write that in my note. Follow the PAD guidelines, pain, agitation, and delirium. They came out with these guidelines actually about 2-3 years ago, and they were published in AACN and SCCM, and they will make recommendations. The Society of Critical Care Medicine has made recommendations based on the level of evidence, scientific evidence. So if they recommend an A next to that number, it's high-grade evidence, B is moderate, and C is that there's very little scientific evidence, but experts or observations make it recommended practice, okay? So the Society of Critical Care Medicine and the PAD guidelines have really focused on treating pain, okay? Recognize and treat pain very aggressively. So the first drug that we should be using in the ICU is fentanyl or morphine. That's your number one sedative analgesic approach. You always start with that, okay? And whether you give boluses of fentanyl or a drip or boluses of morphine, generally we don't want to use dilaudid in the ICU. Why? Because it takes longer to kick in and it lasts longer. So you want to use short-acting drugs. Fentanyl kicks in the fastest and will get out of your system the fastest. So that is why the Society of Critical Care Medicine has generally recommended fentanyl. And a fentanyl drip, if the boluses don't work, should be started pretty soon as you admit a patient to the ICU and intubate them. That should be your first drug. Opioid should be your first line drug for non-neuropathic pain. That's a recommendation 1C. All right? Then they say that when you do sedate a patient, ensure that you don't zonk them out. Okay, Wes Ely calls it submersion. Okay, Wes Ely from Vanderbilt explains it this way. If the patient is underwater, okay, if they do not wake up, they're submersed. They're underwater. You got to let them emerge from being underwater. So you have to use a scale, which we call the RAS scale, okay, the agitation sedation scale. Then you have to maintain a light level of sedation. Generally, the recommendation is a RAS of -1 or -2 at the most. You don't want to get below -3. Certainly not a -5 or a 4, where the patient doesn't respond to sternal blood, okay, or voice. So, light cooperative sedation. Remember that, light cooperative sedation, especially during the daytime. And the RAS, there are other scales, but we're using RAS on Cerner. And that's a recommendation B. Non-benzos. Do not use benzos. Okay? The only time that benzos are appropriate is in alcohol withdrawal and seizures. And the third one is if they're on chronic benzos, you don't want to stop it suddenly. But if the patient is benzo naive, benzos are not good drugs. So we want to really get nurses and doctors avoid using benzos. Okay, so Versed drips, Ativan drips, okay, Restoril for sleep. Even that is a bad drug. They're bad drugs, and if I have time, I'll explain why. Then they're also recommending use Precedex, okay, or dexmedetomidine for delirium to prevent, and also when you do have delirium, it's probably the only drug that has been shown to reverse delirium symptoms, all right? And then the other thing is that we're going to talk about is to interrupt the sedation every day, all right? And then there's some screening tools that we'll use. So when you assess the patient for sedation and analgesia, first thing is prevent pain. Always focus on the pain. Then you also look at patient anxiety. Are they clutching the bed rails? Okay, and we have a tool for that called CPOT, which we'll talk about later. Patient ventilator synchrony is another way of assessing the patient. If they're bucking, fighting the ventilator, auto-peeping, all right, breathing at 30, then they're not going to get rest. The diaphragm is never going to be rested. So focus on how comfortable and how synchronous. One of the things that they've found is actually when patient does not have ventilator synchrony at night, they're not going to get REM sleep, right? Duh, that's obvious, right? So I find patients have been fighting the ventilator all night. It's like they've been in 24-hour fitness. They're in the gym all night. Of course they're not going to get any REM sleep. Next morning they're delirious. So for the night shift, this is so important to walk around, okay, at 9 o'clock, 10 o'clock. Make sure all your patients on the ventilator have synchronous breathing. They should be completely synchronized to the ventilator. If they're bucking the ventilator, the alarms are going off. It's going to keep them awake, number one, the alarms. But the fact that you're fighting the ventilator is actually exercise. It's going to increase your adrenaline, make you delirious, make you tired. You can't get off the vent. All right? It causes delay in weaning. So avoid all of this neurocognitive sequelae. There is now a new term for this. It's called the post-ICU syndrome. And in the nursing journals, you're going to read this, PICS. They're having big talks at SCCM, at your nursing conferences. They're obviously often going to talk about this post-ICU syndrome. What does post-ICU syndrome consist of? Number one, post-traumatic stress disorder. Okay, patients that leave the ICU often come to me, even when we have had a miraculous recovery, they come back a month later. Patients come to me and say, Dr. Habib, can I go into my room? I say, why? So I want to see my room because I'm having nightmares. You know, and then they come and talk to me and say, why am I having nightmares, Dr. Habib? You know, can you explain that to me? And I often send them to the New York Times article, Nightmares in the ICU. It's a common problem. So that's the first thing. The second thing post-ICU syndrome consists of is that patient's brain function is equivalent to a patient with dementia. 6 months out, Okay, young patients in the ICU, they have neurocognitive dysfunction. They can't go back to work. If you're an accountant, you're a teacher, you're a doctor, you often will not be able to go back to work for 2-3 years. Okay, doctors that have been in the ICU cannot practice medicine again for 2-3 years, right? And the third part is the neuromuscular failure. They often end up with severe myopathy, and you've all seen this, right? The patient cannot walk. Their muscles have shriveled up, and their legs have become noodles. You try to get them up, and they collapse. Well, guess where they end up? They end up in a nursing home, they end up on rehab, and we constantly have to get physical therapy to, get their muscles back in order, okay? So the biggest problem that we've found in the last 10 years is that people that have worked in the ICU for the last, 10, 20 years, we always over-sedated patient. And guess what? The recommendation from the Society of Critical Care Medicine 10 years ago is to use benzos. That was the #1 drug. If you look at the sedation guidelines prior to the most recent one, guess what the #1 drug they recommended was? Ativan and Versed. So there are two things that the old guidelines recommended, which are now, basically have been shown to be absolutely dangerous. One is benzos are bad, and the other thing is over-sedation is bad. And the reason we used to think that we need to keep patients sedated is because we didn't want them to be in pain or discomfort. So all the nurses and doctors that come around, they see, the patient is awake and they're not ready to be weaned, they'll turn up the sedation. And they never stop the sedation until they met weaning criteria, which could take a week. All right, for everything to look pristine, the x-ray would look pristine, we would wait for it to be a rosy picture before we started weaning trials. We'd never get patients out of bed, so they'd all be myopathic, right? So we've all been there. But it turns out that increases your risk of delirium. The longer you're in the ICU, the longer you're on the ventilator, the longer you're on sedatives, especially benzos, you are going to become delirious in 24 hours. All elderly people become delirious in 24 hours. All right, so here's what happens. You have an ICU patient, they're mechanically ventilated, we feel a compulsion, zonk them out, knock them out, which I think for the first 12, 24 hours when they're on a lot of PEEP and they have ARDS, it's fine, okay? You're not going to start weaning in the first 24 hours in ARDS. However, as soon as their physiology is improving, you need to start waking them up. You need to start mobilizing them, and you need to turn the sedation off. Okay, and this is where I find nurses often get confused, because when I tell them, zonk this patient out, it's in their first 24 hours. Okay, and then when I tell them, you need to wake the patient up, they often get confused. So you told me yesterday to zonk this patient out. Now why are you trying to wake them up? Because they're getting better, right? They're getting better, hopefully. But in the first 24 hours, you do not want them to be awake at night. You've got to zonk them out. So there's this paradox. I'm telling you to zonk them out, but then I'm telling you to wake them up. It depends on the phase, right? It depends on the initial phase, or are they ready to be weaned? So here's what we talk about now. The ABCDE Protocol. This is standard operating procedure in every good ICU. Every good ICU should know what ABCDE Protocol is, which has been around for actually about 8 years, in 2009. They came up with the ABCDE Protocol in 2009. What does it mean? ABCDE Protocol means ABC, awake the patient, start a breathing trial, and choose the right drug. C stands for choosing the right drug. D stands for delirium assessment and prevention and management, and E is early mobilization exercise, and they often add F. F stands for family involvement. So A, B, C, D, E, F, okay? So here's the thing. If you have a patient on Ativan, this is from Vanderbilt University, okay? If a patient gets about 5 milligrams of Ativan in the first 24 hours, your risk of delirium is 100%. 100%. This is a drug we want to keep away from, Ativan. The other thing about benzos that we know is it actually suppresses your immune system. It paralyzes the macrophages in your lung. So it also reduces white cell response, so you're going to get VAPS, ventilator-associated pneumonia, you're going to get surgical site infections, you're going to get line infections. Benzos are immune depressants, so is propofol. All right, so these drugs actually decrease your immune system too. So there's many adverse effects of benzos that most people are not aware of. Okay, so ABC means you awake the patient. SAT means spontaneous awakening trial. SBT, this is standard operating jargon now. Have you done an SAT, SBT? So nurses look, what the hell is that? What's an SAT? What's an SBT? SBT is spontaneous breathing trial. And C, when the patient is delirious, you have to recognize it and make sure you get rid of the deliriogenic medications. All right? And ICU sedation is a balancing act. See, this is what we often talk about on AM rounds and also at night. Okay, you could make somebody, make sure that they're comfortable on the ventilator, but make sure you don't over-sedate them. Okay, it's a skill. It's going to take time, especially when you have a lot of new nurses. I think that the nurses who've been in ICU for a couple of years, they recognize when the patient is over-sedated, and they recognize when they're too agitated, right? And you're constantly changing the doses of the drugs. Then often you're upping the sedation, and then you're playing with the sedation and the analgesia, okay? So if you don't sedate them, if you don't give them enough pain medicine, then they're going to be awake. They're going to be in pain. The Foley is going to hurt. The central line is going to hurt. The sternal wound is going to hurt. The belly wound is going to hurt. They're going to start bucking the ventilator. They're going to get agitated. If that happens, you know your patient has not slept. So one of the key nursing tools that we started talking about on our multidisciplinary rounds is for the night shift to always report to the day shift the quality of sleep. Did they sleep? How many hours? Was it an interrupted night? So I think I would really like to see that implemented in our AM rounds, okay, as part of our checklist. Add the quality. And what did you do to improve the quality of sleep? There's a lot of things we can do, all right? Some of the things is the noise level. We do labs at 4 a.m. Then we do a chest x-ray at 4:30. A lot of hospitals, even at Lodi where I work, we actually stopped doing labs at 4 o'clock. Okay, a lot of hospitals have stopped doing labs and x-rays and not do them before 6. You want to make sure that your patient gets at least 6 to 7 hours of uninterrupted sleep. Don't wake the patient up for routine vital signs. If they're stable, if they're sleeping, just watch their monitor. Don't wake them up for anything. It is so important. So loss of sleep in the ICU, loss of REM sleep, is a major contributor to delirium. All right? And when you get delirious, guess what? Your immune system breaks down too. Loss of REM sleep breaks down your immune system, so you're going to get septic in the ICU. Excessive sedation, on the other hand, you're going to end up longer in the ICU, which costs us money, right? And it costs us life, because the longer you're on the ventilator, after 5 days of ICU on a ventilator, your mortality is going to shoot up. So you have about 5 days where your mortality is like this. After the 5th day in the ICU, your mortality rate doubles, right? Why? Because you're going to get the central line infection, you're going to get the cowdy, you're going to get the myopathy, you're going to get atelectasis, all kinds of stuff, right? So you want to get the patient. I like to get my patients off in 5 days. If they're not in 5 days, I have problems. Okay, so there's a lot of problems with excessive sedation. All right, so what are we going to do? We got to have a structured, targeted approach to our patients in the ICU when it comes to sedation and analgesia. So we're going to use targeted goals. We have scales. For pain, it's CPOT. For sedation, it's RAS. And for delirium, it's called ICU Cannon. All right, and we have to learn those. And then you have to make sure that you use your medications judiciously and at the lowest possible dose. All right. So it's patient-focused drug selection. Use the RAS score for sedation. Don't go over -3. Try to keep them at -1 or -2. And at nighttime, you might want to go up a little bit to make sure they're not fighting the ventilator, but never should they be above -3. So if you come in and the patient is not responding to a sternal rub, they're submerged. They're underwater. Now you just increase their risk of delirium, right? Use the best drug. Analgesia over sedation. Analgesia over sedation. Remember that. fentanyl over benzos. All right, and a lot of hospitalists still like to use at nighttime benzos. You can dissuade them, discourage them, say, "Doc," and we can make this part of our protocol. You're always going to start with fentanyl drip before you go to Versed drip. ER doctors like to start Versed drip in the ER. They never think about fentanyl drip. Change, right? We got to change. All right, and then frequent evaluation. Use the PAT guidelines from SCCM, and we can actually make a little summary card for all the nurses, and interrupt the sedation whenever it's safe. So you got to do it safely, right? You got to make sure that you wake up your patients when they're physiologically stable. And that could be as early as the next morning. Or you might have to wait 48 hours if they have very bad ARDS, because you might be even paralyzing these patients in bad ARDS. So that's why they have the screening protocol. All right, so this is the safety screen for an awakening trial. No active seizures, no alcohol withdrawal, no agitation, no paralytics, no myocardial ischemia, normal intracranial pressure. All right, that's your safety screen. And then you wake them up. You start waking them up. And you generally want to cut the sedation down pretty fast. The fentanyl, the propofol, the benzos. Precedex is a drug that you don't need to stop. We can extubate people on Precedex. So with the exception of Precedex, ask yourself, what is my sedation and analgesic that the patient is on? If they're on analgesic and sedation, wean those down. Okay? If they start becoming agitated, tachypnic, okay, they start getting destabilized, they start getting arrhythmias, tachycardia, tachypnea, sweating. At that point, your awakening trial has failed. However, if the patient remains calm at a RAS of 0 or -1, then what you want to do is you want to start doing a spontaneous breathing trial. So this has to happen first, then you start a breathing trial. But there's a safety screen for that too. And that is the patient is not bucking the ventilator, they're not agitated, they're less than 50% oxygen, they're on less than 8 of PEEP. I actually start weaning even on 10 of PEEP, because a lot of obese patients might be on 10, 12 PEEP. Don't worry about the PEEP, okay? No ischemia, vasopressors, they're stable, they're not having any ischemia or hypotension or shock. And then there's a breathing trial, which is generally a pressure support of 8, and leave the PEEP at wherever they're at, and you let them breathe on their own. Once they fail, which is designated by tachypnea, they're desaturating, or they're having respiratory distress, they're sweating, they're getting tachycardia, and I also look at the end-tidal CO2 here. If the end-tidal CO2 goes up by 8 or 10, they generally have failed. In which case you stop the weaning trial and you resume the sedation. Now here's the thing, when you resume the sedation, you resume it at 50% of their previous dose. So if they're on 50 mics of propofol, then you got them down to 10 for the weaning trial. They fail the weaning trial. You're not going to go back up to 50. You're going to go to 25. Okay? And generally after the first day or so, you want to start thinking about adding Precedex or dexamethasone. So wake up the patient safely. No seizures, no alcohol withdrawal, the delirium is over, they're not agitated, they're not pulling everything out. Make sure they're not having any cardiac or neural problems, increased intracranial pressure. And then the breathing part, make sure that their chest x-ray is improving, their blood gases are improving, their respiratory status is improving, and then do an SAT and an SPT, okay? Again, how do you do an SAT safely? Make sure that they are awake and cooperative. They might be slightly sedated, but if they're able to be aroused with just general touch on their face or eyes and they're cooperative and they're not jumping out of bed, that's a safe way of waking people up. All right, if they pass the awakening, then go to the SPT. All right, but it shouldn't be done simultaneously. This is what I often find, that they're trying to do the SAT and SPT at the same time. It should be done sequentially. Does that make sense? Do it sequentially. So yes, it does take about an hour, all right, to do it sequentially. And then you're monitoring them for delirium. So what is delirium? Delirium means that the patient has lost awareness of their surroundings. To me, that's a very basic way. It's organic brain dysfunction. It's an organ failure of your brain. Just think of it the same way as you ARDS or renal failure, kidney failure. This is basically your brain is now maybe hyperperfused, that cytokines in the brain, they're inflamed, you didn't get enough sleep. It's an organ failure. Delirium is your brain organ failure. All right, and it's acute. That means if you have dementia, yes, you can still have delirium. But most people who get delirium don't necessarily have to have dementia. They don't necessarily have to have alcohol withdrawal. Any of us could have delirium, okay? And you have to be able to assess it in a scientific manner. That's the problem. We have never been able to assess delirium in a scientific manner. Most nurses say, oh, it's delirious, okay? And they generally rely on this, hyperactive delirium. Guess what? That's not the most common type of delirium. When they're pulling off their restraints and you're putting on mittens and they're tugging on their Foley and their central line. Oh, they pulled out their central line. Doc, can you put another one? Okay. These patients are hyperactive delirium, right? But that's not the most common type, right? The most common type is actually mixed. And even more common than hyperactive delirium, which we miss often, is the hypoactive delirium. That means you've turned off all the sedation and they don't wake up. They act like they're in a coma. They barely open their eyes, okay? Their affect is completely flat. They don't follow commands. This we miss all the time. Then we send them for a CAT scan, which comes back normal, right? Always comes back normal. Doc, I think the patient's had a stroke. Why? Why do you think she's not responding to sternal rub? I turned off the propofol. I turned off the Versed. But sometimes these drugs do linger for 24, 48 hours. Dilaudid will linger. Versed will linger for days. Ativan will linger for days. Okay? So sometimes you don't know if this hyperactive delirium is still the medication in their system or it's just that they have delirium. All right? The other thing that I often find is that one nurse says the patient is not delirious and 3 hours later the nurse says, oh, the ICU Cannon was positive. Well, guess what? That happens all the time. That is perfectly legit, because sometimes the thing about delirium is it waxes and wanes. Sometimes they're hyperactive, sometimes they're somnolent, and sometimes they're completely with it. They'll squeeze your arm, show you 2 fingers, give you a thumbs up, and you come back 4 hours later and they're pulling everything out, okay? So this is the cycle of delirium. There are 3 types of delirium: hyperactive, hypoactive, and mixed. And this is the most common. All right. Once you get delirium, you're going to increase their length of stay by about 2 to 3 days. All right. The hospital length of stay goes up. Their ventilator day goes up. It costs us $10,000 more per patient. And in JAMA recently, just last month, there was another study where they used Precedex. All right, and they found that Precedex reduces length of stay in the ICU. ICU mortality doubles with delirium. The hospital mortality doubles, and there's a 3-fold increase in risk of death. All right? So we often think of delirium as, oh, grandma got confused with their pneumonia, we accept it. Then you tell the family, this is part of being in the ICU. We got to stop accepting delirium as being part. We can do something about it, we can prevent it, we can treat it. Again, where's Ely? 2001. He's been working on this for 15 years. All right, and his group. So they came up with this ICU CAM, all right, where you have the CAM ICU score, where you see that the patient is agitated or they're hypoactive. The first thing you got to do is make sure that the RAS is below -3. You cannot do an ICU CAM if they're submerged. So you got to lighten them up. Stop the sedation, lighten them up, and then you see if they have inattention or altered level of consciousness or disorganized thinking. And how do you do that? You actually have to do an ICU CAM, right? Which I think that the educators will be teaching the nurses. So identify that the patient has delirium. So you do an ICU CAM, and then you mention it on rounds. You identify the risk factors. Many of them are sedation, the sedatives, steroids. It's not always the benzos or narcotics. Steroids, big role. Just being septic, all right, not getting enough sleep, mention that they haven't slept for 2 days. All right, that's part of our rounds every morning. Let's talk about that. So here's what you got to do. You got to think, why is my patient delirious? Think stands for toxic situation, hypoxemia, infection, immobilization, non-pharmacological interventions were not being used. They can't see, they can't hear. We've had a couple of patients, they were completely deaf. They needed a hearing aid. We need to get those. Sleep protocols, start music, open the drapes. Every morning, okay, open the drapes. Check their electrolytes, all right? Make sure that you're using day and night, okay? Because you need to reverse that sleep cycle. So, this is your RAS, okay? Once you get into red territory, a -4 or 5, that should be such a red flag to all of us. You walk into a room, you're having to do sternal rub, and if you do that for 24, 48 hours, that's such a red flag. We over-sedated that patient. Now it's going to take them 48 hours to wake up. We want to keep them over here, okay? As much as possible. As soon as they become hemodynamically stable, think about all the things we could do, all right? Noise reduction, back massages, turn on open the drapes, turn on the music, okay? Have them bring magazines, soft toys, family at the bedside. There's certain rooms that cause more delirium because there's no light in there. All right, have a big window. Okay? Have a clock. Give them their glasses. You guys use that iPad. It's great, great. Okay, keep them interactive. Don't zonk them out. Wake them up. Keep them interactive. I talk to my patients all day long if I could stand there and do that. Okay. Avoid certain things like dehydration. Avoid Foleys. Avoid central lines. Okay, I know we like to have central lines in, but guess what? Foleys and central lines cause delirium. They cause delirium. All right? Help them. Don't do labs at the middle of the night. Don't wake people up at 3 or 4 o'clock. It's such, see, a lot of this stuff that we did, we never questioned it. We thought, oh, this is automatic. How can we not do labs at 4 o'clock? Because the doctors will get upset if they're not back by 7. Well, guess what? Labs can be turned around in an hour. And if I don't treat their potassium of 3.4 till 10 a.m., is it really a problem? Or their magnesium of 1.8 if I treat it at 9 instead of 6 a.m. and call the hospitalist? Is it really a problem? We need to think about what's important for the patient, not for us. Right? We practice medicine for us. All right? Make sure that there's plenty of relaxation. And then the last piece is try to get the patients out of bed, even if they're on 60% oxygen. Doesn't matter. If they're on 60% oxygen, 12 of PEEP, sit them up in the chair. Dangle them at least. So here's what they recommend. Then look at this, the difference in patients that were mobilized, the difference in mortality, just the hospital mortality changes. Okay, they get off the ventilator faster, they get less delirium. What we used to do is actually when patients got delirious at night, we would just get them up in a chair, even if they're on a ventilator. So we never use sedation. We never use Ativan. Benadryl is a very bad drug. Keep away from Benadryl. Do not give Benadryl as a sleeper. Do not give Ambien. Do not give Restoril. All of those drugs are bad. The best thing for sleep is to get them up in the chair before they go to sleep. Walk them in the room. At 9 o'clock, walk them in the room. Walk patients before it's bedtime. The only drug that's safe, perhaps, is melatonin. Okay, there is no safe sleeper. Next to that, something more significant sleeper would be Seroquel. Benadryl is out. There's a Beers list of what drugs not to use, and all of these drugs are on the list of drugs to avoid. Benadryl being a #1 culprit. Any antihistamine is going to mess people up. All right. So surgeons love to give Benadryl. Okay. Again, doing a safety screen for ambulation is the patient should be awake, a RAS of -1, hopefully, and the ventilator status should be stable. So even if they're on 60% oxygen, they're on 10 of PEEP, you can get them in the chair. You can dangle them. And there's a protocol, all right? And you want to try to get them up early, wake them up early in the morning so the physical therapists come at a specific time, after 10 o'clock, when the nurses have done their other stuff, the doctors have done their rounds. And the physical therapist on rounds will ask you, is this patient had passed the safety test for ambulation? And so that's for us. You know, the physical therapist is not going to make that judgment. That's our judgment to say to the physical therapist, yes, I want the patient to be dangled. I want them to be up in a chair. So basically what you want to do, again, keep away from a rat. This is red zone, -4, -5. We should never get there. But the only time I get to a -4 or -5 is if I have an intracranial bleed, I have an open belly, I'm paralyzing patient. But even then, okay, we don't want to have -4, -5. If you stop the sedation, if you got to a RAS of -2, is their ventilator stable? Are the hemodynamics stable? You start with active, but you don't need physical therapy for that. Nurses can do that, range of motion. But when you get to sit and dangle, which is the next step, dangle at the edge of the bed, then I might probably want to get physical therapy there, especially if it's a heavy patient, right? But, you know, somebody that's 100 pounds, the little COPD or lady, we could do that ourselves, right? And then you want to transfer them into a chair. And then march on the spot, walk in the room, and then the next step would be to walk in the ICU. And you have to get the RTs to ambu bag them and take a chair behind them so that when they get tired, they sit down on the chair and then you start again. All right, so we used to do that all the time. And you progress until discharge. So this is a summary slide, okay? ABCDE, await the patient, start a breathing trial, coordinate all the aspects to prevent delirium, not just choosing the right drug, making sure you keep away from bad drugs and sleepers, make sure they get a good night's sleep, all right? Choose the PAD guidelines, check for delirium every shift, okay, ICU Cannon. If they're ICU Cannon positive, then on rounds, you address it. Use the thing. Why is my patient delirious, which is that previous slide. And then also use mobility, because mobility actually reduces delirium, okay? And what's the goal? Get patients out of the ICU faster. We could save at least 2 days on every patient. Guess what? 90% of, there's a recent survey that just came out, you might have seen it last month. 90% of ICUs today in this country, United States, after 10 years of data on mobilization, 90% of ICUs don't mobilize their patient. Even university hospitals. I get patients back from the university hospitals and they never mobilize the patient the whole entire time in the ICU. Sometimes probably community hospitals are doing a better job. It's pretty amazing. After all the data on mobilization and ABCDE bundle, 90% of ICUs do not implement ABCDE. Pretty interesting, right? Okay.